My name is Christine Unerheim. I'm a research fellow at the UCL Center for Gender and Global Health and also an affiliated member of MRU UCL. So we're very excited to launch this webinar on the health of single male labour migrants as a part of our webinar series on borderings, gender, migration and health. This is our first webinar and we look forward to discussing with all of you. I'll start off by some introductions about what this webinar is about, but also about the series more generally before we turn to our very interesting panelists that will share their insights with all of us. I'll then have some questions for them before we open up for a question towards the end of the seminar for the last 30 minutes. So if you have any clarifying questions, please type them in the chat. And if there are general questions, please keep them towards the end of the seminar. So this webinar series, Borderings, Migration, Gender and Health, is a collaboration between the UCL Center for Gender and Global Health, UCL Migration Research Unit and Lancet Migration. And it really aims to draw the attention to the intersection between migration, gender and health, which we think is an extremely fascinating and important area, but perhaps not one that has gotten sufficient attention. So over the next academic year, we will discuss this topic, hoping to promote dialogue in this area by exploring different series topics. So please stay tuned for our 4 planned webinars and then, if possible, day-long event next year. But as COVID has shown all of us, we will have to see what is possible. But we're truly thrilled to launch this series, and I'll start to explain a little bit why we think this topic is of particular interest. So the title of the webinar series is Borderings, reflecting upon borders and what does borders really mean. I think many of us think of it as like borders on a map, but borders also apply to how to our everyday lives. We can think about migrants, citizens and the borders in that dimension. We can think about women, men, non-binary people and those borders, or we can think about the healthy or the ill. So these borders are not neutral and they're laden with associations and meanings. We are particularly interested in gender in this domain because gender relates to and reflects on migration. So gender influences reasons for why people migrate, who migrants, and where they go on their journeys, whether it's before they leave, when they are in a new country, or later on. And what we also know in the area of health is that health risks are gendered and shaped by gendered. Still, the gender dimension of migration and health is understudied and needs further exploration. This is why we want to draw attention to it, so stay connected with us online in our websites or on social media. But let's now turn to the topic of today, which is a slightly provocative question. Are single male migrants neglected, and are we neglecting their health? We have asked this question with focus on the Gulf and have asked key experts to share their insights on this topic, on migration and migration health, to reflect upon it and provide some new insights. Both on the topic, but also in terms of how do we move forward. So we framed this as a provocative question that you could potentially answer yes or no, but what we really want in this webinar, but also in the series more broadly, is to provide that nuanced discussion and insight so that we can understand the dimensions between migration, gender and health more carefully. So let's have macro look at the population we're going to discuss today. So if we look at international labour migrants, which are people who move from one country to another country for the purpose of employment. We consider these people international labour migrants. And this group is actually the biggest of all migrants in the world. And the health of the 164 million international labour migrants is actually not that well understood, despite that it's the biggest population. So a study looking at the migration health literature published between 2000 and 2016 showed that only 6.2% of those papers actually looked at labour migrants' health. So I think we need to understand their health better. When we look at the demographic of international labour migrants, we see that 60% of them or so are men. So we see that it's not equal. And when we start looking at the nuances or the demographics in countries or regions such as the Gulf, we see that there are differences that we should be aware of. So in some of the Gulf countries such as Qatar, more than 80% of the labour migrants are men. What we also should think about when we talk about international labour migrants is what kind of work do they do? So in terms of the single male labour migrants we are looking at today, many of them are in the new country only for a short period of time, which has implication for their understanding of the context and also understanding of their rights, but also in terms of how do policies actually include these temporary migrants. So with this context in mind, this webinar focuses on the health of single male labour migrants. We posed the question, are they neglected, and is their health neglected? If they are neglected, we should ask, why is that the case? And if we think they're not neglected, we should reflect upon who is concerned with their health. I think the past months have also illustrated that the health of labour migrants is of concern, or at least suddenly of attention of the media when we have seen the outbreaks of COVID-19 in some of the labour migrant camps, and also attention to their crowded living environments and working conditions. This again stresses the necessity for discussing their health and their conditions even more, both in a short-term perspective, but also in a more longer-term perspective. And in this webinar, we will discuss some of these issues, but also turn towards looking at what are the implications for research and policy if we are concerned with or if we are neglecting the health of single male labour migrants. So I'll turn over to our first panelist, who is Dr. Cole Rickromach, who is at the UN Migration Agency, or IOM as we know them, where he is the head of migration health research and epidemiology. And they are responsible for providing technical guidance and advancing research and evidence generation on migration health. And prior to joining IOM in 2009, Cole worked for the World Health Organization in various health action crisis program. Now, he is working on a broad spectrum of migration health projects, spanning from the post-conflict health systems recovery in Sri Lanka to the West African Ebola outbreak response, or looking at the health impacts of low-wage migrant labour workers and their family in South Asia. Cole is very passionate about supporting migration health scholarship, and he was also key in establishing the Global Migration Health Scholars Networks in 2016. So I'll leave it to you to continue from here, Cole, but I'm really excited to hear more about your insights on the challenges of obtaining data and conducting research on the health and well-being of male labour migrants from low and middle income countries. So thank you for joining us from Manila, Cole.
Thank you so much, Christine. Can you all hear me? Okay, great. I'm just going to share the screen. I've got a very short presentation. if you just bear with me. So first of all, well, thank you so much for the invitation and also an opportunity to be part of what's essentially this inaugural Borderings session. So thank you so much, Christine and UCL. I think, as you mentioned, the question is indeed a provocative one. The valence of single male migrants and their health is really a strand that hasn't had much traction, or indeed within policy and research circles, and we'll go into a little bit more detail. But when we were deciding on the sort of the content of the panel, the panelists also asked me to provide a quick overview or the anchoring of what we kind of know within the literature, but also the numbers in terms of the gendered perspective. So as Christine mentioned, amongst migrant workers, international migrant workers, men outnumber their female counterparts. In ILO estimates, this is around 41.6% versus 58.4%. And also in terms of the distribution of international migrants, we know that about 2/3 are found in 3 regions or sub-regions of the world. The Arab states, 13.9%, North America, 23%, and then Northern, Southern, and Western Europe at 23.9%. So, but the sub-region with the largest share of migrant workers as a population of all workers is within the Arab states, that comprises of 40.8%. And so in this particular region, there is, and this is the focus of our panelists as well in terms of our sort of research interests and the lens to which we will approach this question that's been posed provocatively by Christine. It's a busy slide, but I just want to appreciate the Gulf Cooperation Council, and I think Wafo can go into details about the different policy valencies around this as well. So the GCC, or the Gulf Cooperation Council, comprises of countries such as Bahrain, Kuwait, Oman, Qatar, Saudi Arabia, and UAE. And really the influx of South Asian migrant workers started in the 70s due to the oil boom in the region. And these migrant workers, mainly from Asian countries, contribute a great deal to their GDP in their countries of origin. So this was accounted as $78 billion from South Asia alone. So this is the sort of the larger mobility corridors, I suppose, if we can say, from the South Asian labor sending countries, Sri Lanka, Indonesia, Nepal, Philippines, etc., to the GCC, the labor receiving region of the world. And so the valence of this question that we're exploring is really on that node. Thought it was important to quickly touch upon, when we talk about the health of migrants, using the social determinants of health model, one of the critical determinants is on those proximal and distal determinants, but in particular the occupational determinant. And I think this is where we have seen a lot of the research focused on, and we will go into that in detail. But also when we talk about understanding migration health and the determinants of health, we have to consider the cyclical nature of migration at the pre-migration phase, at movement phase, arrival phase, and then return. So this is indeed the praxis to which research on migration health rests on. And I always give these 2 slides just as a way of anchoring the discussion, because I think for newcomers into the domain, I think it's useful to always reiterate some of these larger frameworks. What is absolutely clear is that when we look at the who does the research and what do they research on, there is a disparity. And that disparity is in who produces the data on what migrant category. So despite international migrant workers, despite them comprising 60% or almost 60% of international migrants, only 6% of the research output is focused on these migrants. So even before we get into the valence around male migrant workers, and indeed that subcategory of single male migrant workers, it's important to appreciate the lacuna of the evidence base. And I think, as Christine mentioned, there is a, the heat map, if you will, of where research is published is very much within a global north praxis. And also, there's more that we know in terms of research output on refugees and asylum seekers than we do, for example, of the documented labor migrants. And of course, there's also, if you take a deep dive into what research is done on these labor migrants, there's also sort of a balance on that. Again, this is a very brief introduction into the topic, so I don't want to spend too much time here, but just want to appreciate the evidence gap. And I think this really maps out when I started to take a deep dive into this question to which Christine posed. And I think, there's very poor systematic data, systematic reviews and narrative analysis on this question of male migrants and indeed single male migrants. So this is some work, this is a review that was done by Mark Schenker and Sally McCoy. This was published in the Annual Review of Public Health. And that the particular section on gender has very low, they had very little to provide us any insight into the male experience or the experience of those male migrant workers pertaining to occupational health risks. This was the study by Aldridge that was done in the Lancet Migration, and this was on mortality analysis, and it was a really key paper talking about the mortality dividend. The authors here as well concluded this lacuna in evidence on labor migrants. So only 6 studies were factored into the final analysis of labor migrants compared to 110 for refugees and 144 for asylum seekers. So again, iterating that earlier point on research productivity. But of course, we have within the literature specific systematic reviews on, in this case, female domestic migrant workers, and this was work by Rahul Malhotra and colleagues at NUS. And so what's really interesting here is that 26.6% of domestic workers are also male, and this is data from ILO. And this proportion actually is higher within the GCC. Yet, it's interesting. And again, being, taking that provocative stance of Christine with the question, really saying, where is, what is the research on male domestic migrant workers as well. And I'm myself susceptible to this. I haven't, for example, much of my work, my scholarship around labor migration is from South Asia. And whilst there's been multiple research studies that we even commissioned, and in this case on domestic maid abuse, again, the valence is on female, right? So, and so this is, I'm propagating this very sort of strand of the research output. So that's what we have in terms of the sort of review and sort of systematic look at this issue of male migrants and their health. But there are indeed studies, specific studies done in certain countries and settings along this praxis. So let's look at some of them. And so this is an interesting paper that came out from Nepal talking about the mortality of Nepali migrant workers and whether there is an increased susceptibility for Nepali migrant workers in terms of death analyses. And what the study showed was there wasn't a significant difference, and indeed a similar study in Sri Lanka was done in 2009, which concluded the same. There has been sort of studies specific to looking at cardiac, in this case, cardiac mortality in Nepal migrant workers. So this was a study that was done that looked at Nepali migrant workers in Qatar. And so what this found was that there was a strong correlation between the heat stress, so again, the occupational environment that these migrant workers were working in this case, in the construction sites in Qatar, and their risk of dying of cardiovascular problems. Now, I can speak ad nauseam about methodological challenges here in terms of how cause of death analysis is done, reported amongst migrant workers, and how that, the processes and the lack of processes, if you will, in terms of mortality analysis of migrant workers. But these are real factors and determinants to anyone looking at studying, mortality of labor migrants, especially in the GCC. I think, Christine, I will end there, and I will reserve my experiences of the policy, advancing policy in this arena for a later point. Over.
Thank you so much, Cole, and I really thank you for providing such a great overview in an area that is still emerging, I think, at its best. I think you highlighted very clear in your presentation that it seems like labor migrants in general is an area we don't know that much about, but also what we know is perhaps not as attentive to the needs and health needs of the male part of that population. So I think we'll return to some of our reflection on why that is the case or not. But let's first then move on to our next panelist, which is Sarah Babar, who is the Associate Director for Research at the Center for International and Regional Studies at Georgetown University in Qatar. And we're very excited to have you with us today in this area and with your expertise in the Gulf and migration in the Gulf. Dr. Babar previously worked for the United Nations Development Programme and also the International Labour Organization. And in her work, she has published several articles and book chapters in this area, including most recently Labour Migration in the Persian Gulf, in the Routledge Handbook of Persian Gulf Studies, Gulf Politics, and on migrant and labor and human rights in the Gulf Cooperation Council countries, and why human rights still matter in contemporary global affairs. So as a distinguished scholar in this area, we're very glad that you could join us today to talk more about vulnerabilities of migrants and in particular male labor migrants in the world, in the Gulf. So I'll give the word to you, Sarah, and then let's hear more about your perspective.
Thank you so much, Christine. And let me echo Cole in saying it's a pleasure to be here, and I'm grateful to UCL and all of your collaborators for organizing this discussion. I think I'll build on some of the things Cole really nicely laid out for us, some of the bigger picture features of this region, of the 6 Arab monarchies of the Persian Gulf and what migration looks like here. As he pointed out, this is one of the largest global hubs that hosts temporary labor migrants, particularly in terms of density and proportionality versus citizens. Figures and data are such a challenge in the region. I think they're globally a challenge on migrants, but here in particular, so the estimates vary greatly. Out of a regional population of about 59 million people, we have the estimate of somewhere between 29 to 35 or 34 million labor, economic migrants. And the vast majority of these are sort of migrant workers. I mean, the vast majority are people who are carrying out manual occupations in the construction sector, but many other also sectors where manual work is needed, and lower tier jobs in service sectors. And again, the demography of these 6 countries is really interesting just to look at the charts, but the gender variation amongst the migrant population is also enormous. So there about 70% of the lower income workers, at least at a minimum, are male. So the population as such that we're talking about, single male migrant workers, has a dense footprint in the region. As Cole again mentioned, there is a paucity of academic scholarly work that studies the health conditions and experiences of single male migrant workers across these GCC states. But there is anecdotal and some journalistic work, as well as a few qualitative studies. And they do highlight that it is the vulnerabilities that single male migrant workers experience when it comes to having their health needs met or experiencing health is not so much about the health architecture and infrastructure and health availability in these countries, but rather it is because of the status and greater conditions that this segment of society here contends with. So lower income migrants have problems which are associated with the fact that they earn, very little. They are low wage workers. They work in low skill occupations. They are vulnerable to potential anxieties around their tenuous position in the GCC. Their jobs are mostly tie them to their employers under particular visa sponsorship arrangements, which means that in all forms of negotiation with their employers and the companies that bring them here, they are vulnerable. And this also has an impact on their health. The single male migrant worker community here, as again Cole mentioned, they tend to, as it is, work in particular sectors which are hazardous by nature, and where there's a greater propensity for sort of physical injury, like construction and other manual labor jobs. They tend to do a lot more outdoor work than skilled and highly skilled migrants. So they're more exposed to the elements, and certainly in the incredibly insane summer months we have here, this exposes them to all sorts of heat-related sickness. In addition to these sorts of conditions, you also have other kind of structural factors, right? You have language barriers, you have cultural barriers. So if male migrants are experiencing issues with their health, it is difficult for them to access appropriate care. But even the language and cultural barriers, I think, are less of an issue than the fact that they are so highly dependent on their employers and the companies that have hired them to bring them out here to work. It is up to these companies really to have provided them with the ability to access healthcare facilities should they need it. The employer holds control over the migrant workers' access to a health card. Now, in the GCC, public health is available almost across the board to lower income single male migrant workers, but they only get access to these public healthcare services through there's these authorized health cards that they receive. And the issuance of these health cards depends on employers' willingness and in getting those done. So in accessing information about their healthcare, migrants also are dependent on their employers to give them information about where they should go and how they should access it. And in all those places, we find that there are challenges, that migrants may not have the ability to actually know what's available, where to seek healthcare when they need it. So again, a lot of the little amount of research we have on this shows that it's not about a neglect per se, in the sense that there isn't a health service that they can access, but it's because of their positionality, and it's because of the vulnerability and over-dependency they have on their employer, who can act seemingly to prevent them from getting timely healthcare, getting their healthcare needs, and making them aware of their options. One of the other factors that I think is important are single male workers' own reservations around their health needs and health access. From very early stages of the process of trying to get a job in the Gulf, these workers, the migrants in their pre-departure period, have to undergo very stringent health screening measures. This is deeply embedded into the visa process. In fact, one of the first things that migrants often have to do is prove that they are in good enough health to get a job out here. Getting a job is a very competitive process. And for many migrants, those early encounters during the stage where they're looking for a job in the GCC, when they're like in some town in Pakistan, if they start associating their good health with their ability to be considered a valuable worker. And so the early encounters with medical authorities are through these health screening processes, which become extremely problematic in that they may leave an imprint on migrants once they're in the Gulf that makes them feel that should they be sick, should they be ill, this will somehow make them not as a valuable employee. And so there's also a tendency for migrant workers to start hiding some of their health information issues. And this, I think, is one of the things that makes me very concerned at the current moment. Single male migrant workers have always been viewed as a community of potential public health risk in the Gulf. And this definitely predates COVID, because many migrants come from countries where infectious diseases, contagious diseases are endemic. There has always been this heightened anxiety on part of the Gulf authorities that they have to make sure that workers coming from those countries do not bring these contagious diseases in with them. And so obviously post-COVID, I imagine that these screening measures are going to get even more stringent, with additional layers of sort of provoking additional layers of anxiety amongst potential migrants, which may serve to inhibit them even more in seeking medical attention, taking time off work, and ensuring that they have their health needs addressed when they are in the Gulf. And I think I'll stop here for now.
Thank you so much, Sarah, for your perspective. And I think you really highlighted how there are perhaps more than us talking about this and neglect. It is more the systems in place and the way people are put at risk through or not at risk, but how their living condition and working conditions and their status, as you say, put them at risk of not being able to seek care when they're ill, because it depends on others' decisions. But also the last thing you bring up about how are they perceived in the countries when they are there. So I think that actually brings us very nicely to what Dr. Wafa Aftab will talk about, looking more at the policies in place with regards to labor migration to the Gulf. So our last panelist is Dr. Wafa Aftab. She is based at the Department of Community Health Sciences at Aga Khan University in Pakistan, and is joining us from Karachi today. She is, in her teaching and research, she focuses on health policy and governance of health systems, including intersectoral action. So in migrant health, Dr. Aftab is involved in a study on the policy environment in Pakistan and Qatar related to structural factors, which we just talked about, and how they influence the health of labor migrants. So I'm very excited to hear more about your work and really to examine our policies attentive to labor migrants' health. So over to you.
Thank you, Christine, for that wonderful introduction, and thank you to the other two participants for, the giving the much broader context of the whole issue. And my work is, of course, in the area of health policy. So that's the lens that I'll be using for the analysis that I present. But of course, we know that health is not just about healthcare. Health is about so many other things. And especially when it comes to this population, as Zara has said and Cole has said, there are issues related to a number of different structural factors. For instance, living conditions, for instance, access to health services, not just in terms of geographical access, but also in terms of financial access, and just things like culture and linguistic barriers. So what we've done in our analysis, while we're looking at one sending country, which is Pakistan, and one receiving country or host country, which is Qatar, we've looked at a number of different policies. Our main focus was on the issue of sexually transmitted infections, because we know that this is an issue since we're talking about mostly young male workers who tend to be sexually active. So which is why we're using that lens. But we're not limiting ourselves to just that narrow lens, being mindful of the other structural determinants of health. So what we found when we looked at policy documents in Pakistan and Qatar was, and I'll take you through it in a way that's structured this around for instance, a pre-departure part of the migrant journey, which is in the sending country, Pakistan, which is influenced mainly by policies in the sending country, and then the other part of the journey, which is in the host country and influenced by policies in the host country. But of course, there are also other layers to it. There are agreements between countries, bilateral agreements, there are regional agreements, there are global issues that have to be considered. But mainly, I'm looking at policies from the two different countries. So when we look at policies in both countries, essentially, but I'll start with Pakistan, is that the main tenor of a lot of policies about this population tends to be around macroeconomic concerns. So we can see in policies in Pakistan that the government has very much adopted a policy of exporting labor as a way of not only relieving lack of employment opportunities in Pakistan, but also as a way of encouraging, foreign exchange. This is a large number of migrant workers go to, especially the Middle East, and it's a rich source of for the national exchequer, and that's something that you see coming through in a lot of the policies that refer to these migrant workers. It's probably not surprising that health is not the main concern in a lot of these policies, but looking at the fact that the government is actually encouraging this migration, it's a little surprising that we still don't have any specific policy related to migrant workers. But within the existing policies, if you look specifically at sexual health and HIV, you see that there are national and provincial HIV strategies within which migrants are identified as a vulnerable population. And what the sort of the solution that these strategies come up with is providing pre-departure orientation to migrant workers. There isn't a lot in the policies in terms of what should be discussed. But there's some concern about sexually transmitted diseases and HIV, and making people aware that these are some of the issues that they should be concerned with. But we know from our experience and from talking to people in the field that because of taboos, because Pakistan because of religious issues, and because people are not comfortable talking about these things, sexually transmitted infections, sexual behavior in general is not something that is addressed in these pre-departure orientations, which are mainly concerned with occupational health and things related to those issues. So in terms of, there's also very little focus about in the spiritual orientation about living conditions, and also the sheer fact that these are people who will be living away from their families for a long time, and what does that imply in terms of their social life. So those are some of the concerns that are really not addressed. Now, one of the really big concern when you think about this whole process from the perspective of HIV, health, and rights is the fact that everyone has to go through, and this is based on policies in GCC that applies to all countries across GCC, although it's hard to find a policy explicitly stating that people have to be tested for a certain number of conditions within Qatar, but we have GCC policies very clearly stating that people have to be tested for a number of conditions. And now that raises questions of rights. So we know in terms of international normative guidelines related to HIV and migration in general, that denying people either migration or employment on the basis of actual or perceived HIV status is discriminatory. And it is a violation of rights. But we see that within policies related to migrant workers, it is very much there, and you see very little mention of concerns with rights related to those things in policies. When it comes to host countries, of course, there's the issue of testing. So part of the policy response that we see in Qatar and host countries can be understood by keeping in mind that for a lot of these countries, before people get there, they have been tested for sexually transmitted infections, and anyone who is positive is usually not allowed to come in. So you see a real absence of any response to sexually transmitted infection or HIV within the policies of these countries. When you look at the broader policy environment, it's very much focused on local populations, and where migrants are referred to, it's in relation to, if you talk about health, in relation to specific conditions, for instance, either occupational diseases related to, for instance, heat stress injuries, or in terms of infectious diseases like, for instance, tuberculosis. But you really, there is no clear policy on sexually transmitted infections, let alone for migrant workers, and so which is understandable to some degrees, because there's also the same issue of taboos and cultural barriers in Qatar as well. So that was a basic overview of what we found in our policy analysis across two countries. I'll leave other thoughts for upcoming sessions. Thank you.
Thank you so much, Wafa, and I think that insights into what does this actually look like when you start looking at it at country level and at policy level. I think that is really interesting to see, and as you say, some issues are absent or not really on the agenda. And I think our discussion about migration and migration health more generally really also needs to these like how we perceive migrants and their rights, and also the power dynamics of policy making and decision making, which is not only an issue about national circumstances, but also relates to the regional politics and geopolitics, in addition to the media discourses that we've seen on migration and immigration for many years. So thank you to all of you for providing insights based on your expertise. And I think based on what we heard so far, I think we could continue for a long time. But before I turn to the audience, I wanted to pose some questions reflecting on the series that we're doing. And I will start off by going back to the questions that I asked on our single male labor migrants neglected. And I think, as we heard earlier in this presentation, there seems to be, as I can see, perhaps within the health literature at least, maybe not a neglect, but at least lack of attention to labor migrants. And then I think there was also some indication that we tend to, when we focus on labor migrants, are we really attentive to sex and gender? And I think in the health literature or health environment that some of us, like me, belong to as researchers, there is an increasing awareness that when we talk about gender and sex, maybe we have been more attentive to women and girls than we have to men's health or non-binary people's health. And I think studies show that actually when you look at policies at national level, you see that there is very little special attention to men's health, despite the fact that men die prematurely. So going back to this seminar, are research and policy responses on migrant workers' health really sensitive to sex and gender? So I think you all touched upon this in your presentation, but perhaps you can say a little bit more on that. And in the case of, if you think it is neglected or not, could you give us some perspectives of why this could be the case? And I know that this is, again, slightly provocative, but I think as we are in this seminar series, it's also a possibility for us to exchange ideas about the reason for why that is the case. I'd like to hear your take on this question, Sarah, because I think in our initial correspondence prior to this meeting, you said, but of course, in a country like Qatar, it's 80% of the male, or more than 80% of the labor migrants are male, so they're definitely not neglected. Everyone is aware of that, right? But in your work, can you comment on some of the aspects that we have been discussing?
Yeah, I mean, the fact is that for most of us, I don't work specifically on health or health policy, right? But for many of us who are working on the social and economic conditions of migrant workers in this part of the world, they vastly outnumber female migrants. So a lot of the research interest from the social science, and even I'd say some of the advocacy and policy-oriented research has certainly focused on the conditions and experiences of male migrant workers. There's also an accessibility issue on looking specifically or trying to study specifically the conditions for female migrant workers is more of a challenge for many people, because particular pockets where they're working, such as in the domestic work sector, are harder to research. They are harder to access. But just on numbers alone, particularly large survey-based data sets are really on the single male migrant worker community. But I mean, I shouldn't mean that this somehow implies that there are no issues. I actually agree with what Cole has said, which is that we have a sort of gendered approach towards considering and thinking of the healthcare and health needs of young male migrants. There is almost an implicit sense that there's a greater need for protection, providing protection to women, and as who are considered more a category at risk sometimes. I think that does come across. I mean, while we were thinking about this, while Cole was speaking, what I was also thinking about is there are some direct disadvantages that the over-visibility of having such a large masculine presence of migrant workers has. You cannot go out in Qatar and in the UAE and in some of the major Gulf cities and not immediately see this visible presence of so many foreign men in blue doing all the hard work around us. This means that when it comes to meeting the health needs, for example, some of the GCC states have decided that rather than have them sort of overtake the public healthcare facilities that are meant to be used by everyone. I mean, people are uncomfortable. They're going in for a doctor's appointment, public hospital, and 80% of the waiting area are all these migrant workers. So they've actually started creating kind of dedicated medical centers just for single male migrant workers. So, and supposedly this is improving their ability to access timely medical care, right? But it also means that they're not really allowed in the common spaces where all of us would go and have our healthcare needs met if we're going to public hospitals. Whereas many of the female migrants are still using those. They're still using the normal health facilities and are not kind of partitioned. And I think that in its own way is a kind of odd and gendered experience, because they aren't actually mingling with the rest of the population when they're getting their healthcare, but they're going to be separate, like worker hospitals.
Thank you, Sarah. I think that's really interesting that you highlight also how in terms of and when seeking care, what kind of healthcare system do they mean? And I mean, research in our health field also show that health systems are gender, and that becomes particularly visible when you have a health system that is sex disaggregated or where it's different hospitals for men and women or settings like that. We'll then turn to a slightly different topic, but also a topic that was mentioned by all of you, which relates to the rights of these migrants and who is really protecting their rights and who are responsible for protecting their rights. So I think I'll first ask you, Wafa, to perhaps expand on what you started off in your presentation, and then it would be very interesting later to hear what your views are on this, Sarah, given your research in this area.
Right. Thanks. Thanks, Christine. So when we think about rights, I mean, I can speak because most of my work revolves around health policy. I can speak more to perhaps the right to health. But of course, the right to health, as I said, doesn't just involve healthcare, but also some attention to determinants of health. So it's slightly broader than just access to healthcare. But I mean, when we look at policies across different sets of countries, sending and receiving countries, I think, and when you think about it from a perspective of rights, one of the problems that you come across is that the right to health is often conceptualized at a national level. That it's a nation or a state that is responsible for ensuring the right to health for its own citizens. And so within that very nationalistic way of thinking about the right to health, when you think about people who are moving across nation states and living in states where they're not a primary citizen, and for this population that we are referring to, it's probably unlikely that they will become citizens and nationals, then it becomes a slightly challenging question. How do you think about the right to health? Who is responsible for delivering the right to health? Is it the sending country? If it's the sending country, how much power does the sending country have to make sure that people have access to services and rights that they need while they're living in host countries? So that's a slightly difficult question of, I mean, we can come to the question of how later, but we're very much at this stage also on the question of who is responsible. And so as Cole referred to, there are many different levels of this. So to ensure at least the right to health and some other related rights, I think we have to, in terms of policies, go beyond the country level and think in terms of more, I mean, not just bilateral, because I mean, bilateral policies also, as Cole said, have a way of turning into a very competitive marketplace where it can become very quickly a race to the bottom. So maybe, I mean, the best way of ensuring the right to health would be to think at a more regional or multilateral level. But I understand that that's probably in some senses easier said than done. But that should be, I think that should get more focus, especially in terms of health and related rights.
Sarah, would you like to share some of your insights on this area?
I will, but I'm going to sound extremely pessimistic and non-hopeful. I mean, we've spent decades trying to just come up with transnational and international mechanisms for cooperating on migration. And we can all see how well that one's going. So if we can't even get states to agree to a proper and effective multilateral framework which guarantees the rights of migrant workers, instead of orphan treaties and unsuitable compacts, I don't think we're going to be seeing a lot of what we need when it comes to health as an international human right. This is definitely a transnational issue. It's not even just governments. We have multiple stakeholders who would need to be involved, including like employers and recruiters and all, you know, different parts of the entire chain that brings migrants to the Gulf from different parts of the world. Because health is a lifelong thing, and it's through the life of the migration process. Of course, it's pre-departure, it's during the stage of migration with the host country and upon return. The problem obviously is that we do lack a lot of proper evidence-based research, and for me, that would feed into perhaps animating the discussion around why it's important to get greater international cooperation on migrants' health needs. And it's two kinds of research we're missing. We're missing the transnational component. We do not have enough longitudinal studies that really track the health conditions of migrants before they even get to the Gulf, and then track their health conditions and status while here, and then continue to follow them for like 10 years after they go home, to actually see overall what these stories tell us over time about what the impact of migration has actually done, whether it's better or worse. I mean, whatever we have, we need to have that evidence to see. We also are really lacking, I think, effective multidisciplinarity in our approach. So I'm a social scientist. I don't know enough about the actual medical stuff, right? And what you see right now is an emergence of studies that kind of focus on the medical condition side of migrants, and then others that are focusing on social determinants, health policies and things like that. So I think those need to be merged. But yes, I completely agree with Wafa. The condition of guaranteeing the right to health for migrants is critical, but the onus on that is on multiple state and non-state people.
Thank you so much for that honest answer, I think. And I think it is really important to recognize what is feasible and possible, and also what we can do and can't do. And I think recent trends there, or not only recent, but long-standing trends, gives us reasons for why we can't be too optimistic. But on the more pragmatic side, I thought it would be good for us to reflect on the policy of responses and what is possible in this context.
I think that I would say from the GCC perspective, and looking just specifically at health and at single male migrant workers, I think the challenge is, and this is not just GCC specific, this is what we would see in many other contexts which have similar density of temporary labor migrants, because you have to remember in the Gulf, it is always the temporary that is emphasized. These men are brought here supposedly on 2-year contracts, which can be renegotiated and frequently are. Some just complete 2 to 4 years and leave. Many stay here longer. But from the lens of public health authorities, this is a transient community the state's duty is to ensure that the health needs they have for that limited period of their lives that they are here are met, that they are not placed under duress, that they are not able to access the healthcare they need, that they are not able to afford the healthcare that they need. But it is seen through that lens. This is not a permanent part of your society that needs to be deeply integrated into your national healthcare framework. You need to have general policies to ensure that this transient workforce, while it is here, remains healthy and does not go home unhealthy. So that has a time boundness to it, right? And I think that what we're talking about is something more than that you bring workers and they're not a transient population. They stay a huge chunk of their life here. So you need a broader commitment, and the state that is hosting them should have a broader commitment. But I think that is how policy is generally geared around single migrants' health in this part of the world.
Thank you, Sarah. And Wafa, do you have anything to thoughts on where to guide us in terms of policy responses based on your work in Pakistan and Qatar, but also in the general reflections or discussions and issues that Sarah and Cole have brought up.
Yeah, so I think in terms of policy, as we've discussed, that there are multiple levels on which we need to work. But as Zara said, it seems that in the near future, the main mechanism of these through which these policies are made and implemented would be bilateral agreements, and that brings me to a question of governance. Which is that when we tried to access bilateral agreements between Pakistan and Qatar, we were refused access to these policies, which has huge implications for transparency and accountability. Which to me raises the question of that there is a lot of advocacy to be had even at the national level. First of all, because I think the public has a right to know what has been agreed. And secondly, I think we have this population of labor migrant workers that is making huge contributions to the country. But when we look at different kinds of migrant population, we look at, for instance, if we look at Pakistani migrants who go to the global north, who are more educated, more professional, they're very politically aware. They're very good at lobbying. But this is a population of labor migrant workers who are not as politically aware. So I see a lot of room there also for advocacy, for people becoming more politically aware, more politically active, and maybe demanding, of the governments that their rights, including health, be a significant contribution in these negotiations.
Thank you so much, Wafa, and thank you for everyone who is listening in and paying attention to what is being discussed. I think we got some great questions touching upon some of these areas. I'll try to direct them to the people I think they were intended for, and then the rest of the panel, please feel free to jump in. To turn to the question on interdisciplinarity that was raised, and I'll try to get to all questions, but I'll give the panel the difficult task of answering these challenging questions as short as possible, being conscious of time. But there is a question on interdisciplinarity for you, Sarah, about what you meant by saying that we need to be more interdisciplinary. And the question is asked by Faisal, who's also a social scientist, and have been trying to collaborate. And methodologically, that has been differently. And I think that's a key question I have also encountered in my research on migration health.
Absolutely. And I wish I had like the super wise response, which I don't. But I think, it is trying to find creative ways. I think there are huge issues when you try and cross, when we do projects which we consider to be interdisciplinary, and it means you have a political scientist and an anthropologist and a sociologist, and we're excited. But the fact is, we do need to try some way to overcome these barriers. I've found it in my research. There are things where I'm looking at it just through my lens, and then I hit a wall because I don't know that other side. If I'm trying to assess what is happening in how migrant workers are accessing health, and I'm just looking at all the sort of situations that are related to their anxieties and the relationship with the employer and whether they have transport and who pays for the taxi. But I don't know anything. I have no insight about what it is that's going on. What are they seeking? Is this a critical thing? I think it's trying to find some way to get over this. And I will say this in support of my science, natural science, biomedical science. I have noticed people on that side, I actually often find it easier to navigate into the space of social science and pull them in, kind of like what Cole is doing. And it is harder the other way around, right? But I still, although I don't have an answer as to how it's to be done, I think there are more researchers focusing on trying to develop those collaborations, eventually will be more successful in doing it properly.
Thank you, Sarah. And I think that's really, again, putting us back on what can we do. And I think it's providing us with some insights on where we may go to expand in this area. And I know that you soon have leave, and I think in the interest of all of us, we should try to close up. But we'll try to answer the final questions. But I know that many of you probably have to leave, and thanks so much for the insights that you have been providing. So I think there is two questions that are slightly related. So there is one question asking about the kind of networks of care and informal community care practices and labor male migrants, and kind of highlighting that there is attention on informal care networks for women and children and families, but perhaps not so much for single male labor migrants. And I think that question, thinking about what does the literature, what do we think about, relates to the question that is being asked about the lack of data, and whether we can use data that are already here. So one suggestion is to use data that we get in sending and receiving countries to actually understand more about those issues. So I think one of the questions actually says, when we look at what is out there, we seem to focus on women and then their networks in some way. And the other question is, can we use the knowledge that already is out there? Leave it to Wafa to try to respond to our last question on remittances, and that says, when the health of the worker is not taken into consideration, remittances will be expected to decrease. But if the supply is always high, there is no push to protect the health of workers, especially from a receiving country point of view. So is then the health workers jeopardized by their transiency and replaceability? So perhaps you can comment on that, Wafa, and then sadly I think we'll have to close up. Yeah, but it would be great to hear some of your work relating to both the sending and receiving country perspective.
Yeah, thank you, Christine. So it's a very pragmatic question, but I'm probably not going to give a very pragmatic answer. So I think I'll go back to the fundamentals of this question. I think what I would, how I would think about this is that, the way remittances and migrant health are often linked in terms of testing, it seems very instrumental. And then the fundamental question is, should health be just be instrumental to other ends, for instance, economic gain, or should health be considered a right in itself, irrespective of any other thing? And so, I mean, and not to give a very long answer, but to go back to the Kantian means and ends things, I think we need to separate the whole economic debate from the rights debate to the extent that I think for as rational free human beings, people have a right to be treated as ends in themselves rather than means for other things. So I would say that it's not necessarily natural to me to combine health and remittances as something naturally linked. I think health is a right in itself, irrespective of anything else that it provides to people themselves or others.
Thank you, Wafa, and for putting it so clearly that health is a right in itself also in this area. So with that, I think we're going to close this seminar or webinar. And I just want to thank the panelists and everyone who stayed with us for more than 1.5 hours discussing these issues on single male labor migrants and their health. I hope we've gotten slightly brighter and wiser as we have moved forward. At least I have, and I hope we can continue these discussions online or in our work that moves us forward. And I think also the fact that we have highlighted that actually to move forward here, I think we need to reach out to people in other areas is a key take-home message here, as for much of our other work. But I really want to thank all of you and stay updated on our website at the UCL Gender and Global Health Center, at UCL Migration Unit, and at Lancet Migration, where we also will be posting version of this webinar. So please stay in touch and keep the discussion going, and thanks again for joining us today. Thanks.